Today we are going to cover chapter 31, which covers the thyroid and the parathyroid drugs and the agents affecting bone mineralization. Hormones that are secreted from the thyroid gland are essential in controlling metabolism. These hormones also work synergistically with other hormones to help promote natural growth and development. The parathyroids are essential in regulating calcium homeostasis, and they're also very important for maintaining proper bone mineralization. So if we have any problems in the thyroid or parathyroid, problems with the function of them, it's usually going to be treated by pharmacological methods. And it's very important for you as physical therapists to understand the pharmacological management of both thyroid and parathyroid function so that you can adjust your therapies appropriately for patients with bone healing disorders and other types of conditions caused by problems with these endocrine glands. The thyroid gland synthesizes two primary hormones. They're named T4 and T3. T4 is also known as thyroxine, and T3 is also known as triiodothyronine. They're named T4 and T3 because of the number of iron residues that each structure contains. So T4 contains 4 iron structures, and T3 contains 3 iron structures. T4 is a precursor to T3, and the conversion of T4 to T3 takes place in the peripheral tissues. Regardless of which hormone may ultimately affect cellular metabolism, both T4 and T3 are needed for normal thyroid function. Even though the plasma levels of T4 are higher than T3, and T4 is going to be the one exerting most of the effects on the tissues, both of these hormones are really important for the maintenance of normal thyroid function. All thyroid hormone production is controlled and regulated by the hypothalamic pituitary system. Thyrotropin releasing hormone, also known as TRH, is released from the hypothalamus, and then this stimulates the release of thyroid stimulating hormone, also known as TSH, from the anterior pituitary gland. TSH will then travel via the systemic circulation to the thyroid gland in order to stimulate the production of T4 and T3. The increased circulating levels of T4 and T3 serve to limit their own production by inhibiting the TRH release from the hypothalamus and the TSH release from the anterior pituitary. So essentially this is another negative feedback loop. And this negative feedback control and regulation of this negative feedback loop helps to prevent peripheral levels of the thyroid hormones from being excessively high. Both T4 and T3 have a direct effect on cellular function, and as I mentioned earlier, they help other hormones to function properly as well. Both T4 and T3 appear to increase cellular metabolism by directly increasing oxidative enzyme activity. And because they affect the hypothalamus, they can affect the central nervous system. They also have an effect on thermogenesis. They increase the basal metabolic rate and heat production from the body. As far as growth and development goes, T4 and T3 both help to stimulate the release of growth hormone, and they both play a key role in the development of the skeletal system and the central nervous system. If thyroid hormones are not present, what happens is severe growth restriction and developmental delays, such as creatinism. The thyroid hormones play a role in increasing heart rate. They also facilitate myocardial contractility, and these two together lead to an increase in cardiac output. These hormones increase intestinal glucose absorption, and they increase the activity of several enzymes involved in carbohydrate metabolism. The thyroid hormones also have the capability to enhance lipolysis, the breaking down of fat, by increasing the response of fat cells to other lipolytic hormones. So in general, these and other metabolic effects that are elicited by predominant action of T4 and T3 help to increase the availability of glucose and lipids for increased cellular activity. So that's how they play a role in eliciting the regulation of metabolism. I definitely want you to pay close attention to the mechanism of action for the thyroid hormones, as they exert their primary effects by entering the cell, and they bind to specific receptors located within the cell's nucleus. So very similar mechanism of action as to how the steroid drugs work. Remember, the steroid drugs work directly in the nucleus of the cells and elicit their responses that way. So the thyroid hormones act as DNA transcription factors, and what they do as the DNA transcription factors is they bind to specific DNA sequences that regulate gene expression. And when they're activated by the thyroid hormone, the thyroid receptors induce the transcription of specific segments, which results in altered protein synthesis within the cell. The non-genomic effects could be mediated by an effect of thyroid hormones on non-nuclear receptors located on either the cell surface or on the cytoplasm or in the mitochondria. But I want you to focus on the main mechanism of action of how thyroid hormones work in the cell's nucleus. So don't worry too much about the non-genomic effects. It's kind of just for your general knowledge. And thyroid hormones also have a direct effect on immune cells. So they may cause rapid changes in immune function that are unrelated to the effects that they elicit on the cell's genome. The two main pathologies that I want to discuss that use thyroid hormones as their primary treatment are hyper and hypothyroidism. So I definitely want you to know the primary symptoms of hyper and hypothyroidism, because I'm not going to say whether it's hyper or hypothyroidism in the clinical vignette, but I want you to notice if the patient's nervous, if the patient's having an accelerated heart rate, if the patient has reported polyphagia, if the patient's heat intolerant. I want you to be able to recognize hyperthyroidism. And the contrary, hypothyroidism, everything is slow and delayed. So we're going to have bradycardia, we're going to have constipation, we're going to get the lethargy, weakness, so on and so forth. So please pay close attention to the table that indicates the primary symptoms of hyper versus hypothyroidism. So you may also hear hyperthyroidism called thyrotoxicosis, and you may also hear hypothyroidism called hypothyroxanemia. So be familiar with those terms as well. So hyperthyroidism is going to be treated with drugs that attenuate the synthesis and the effects of thyroid hormones. So we want to suppress these effects. And on the other hand, hypothyroidism is usually going to be treated with thyroid hormone administration. The thyroid disorders as a whole, they're very complicated. These are the drugs that we're going to mention are the main pharmacological source of treatment, but please note that the patient may be on a plethora of other medications as well. So as I mentioned previously, hyperthyroidism is also known as thyrotoxicosis, and the patient may have an enlarged thyroid gland. One of the pathological conditions associated with hyperthyroidism is Graves' disease, which is thought to be caused by a defect in the immune system. And remember, the enlargement of the thyroid gland is also known as a goiter. So with Graves' disease, because of some type of potential genetic effect, antibodies are being synthesized that directly stimulate the thyroid gland, which result in an exaggerated thyroid hormone production. So the main treatment of hyperthyroidism is to ablate or remove the thyroid gland. The patient can also be treated with radioactive iodine to completely shrink and eliminate the thyroid gland from physiology. The anti-thyroid drugs, definitely want you to know propylthiouracil and methimazole. These drugs directly inhibit thyroid hormone synthesis. So remember, with hyperthyroidism, we're having too much production of the thyroid hormones. So these two drugs are usually used to control excessive thyroid hormone. They're given prior to surgery for removal of the thyroid, or prior to the administration of the radioactive iodine to ablate the thyroid. And iodine. Iodine is really important to know about, because that's sometimes given in order to cause a rapid and dramatic decrease in thyroid function. The radioactive iodine, which I mentioned earlier, virtually inhibits all of the function, the biosynthesis of the thyroid gland, because it essentially destroys it. Sometimes you'll see beta blockers used not to treat hyperthyroidism per se, but they're used to treat some of the sequelae, some of the symptoms associated with hyperthyroidism. So remember, they don't work on the thyroid hormones, they don't work directly on the hypothalamus per se, but they are used to treat some of the symptoms such as tachycardia, the palpitations, and the restlessness during some potential acute exacerbations of thyrotoxicosis. The acute exacerbations of thyrotoxicosis are also known as a thyroid storm. And on the contrary, we have hypothyroidism. Severe adult hypothyroidism may also be called myxedema, M-Y-X-E-D-E-M-A. And this may occur idiopathically, or it may be caused by specific factors such as some type of autoimmune lymphocytic destruction. We talked about Hashimoto's disease in pathology. So Hashimoto's disease, one of the clinical manifestations is hypothyroidism. Comes in many different forms, many different levels of hyperthyroidism, and there are many different thyroid hormones that are used to treat it. Sometimes it's just T4 content given, sometimes it's a combination of T3, T4. There's synthetic, there's natural blends. Again, I don't need you to know the names of these particular drugs. I just want you to know with hypothyroidism, the thyroid function is diminished or it's absent, so we're giving essentially hormone replacement therapy. So we're administering the natural thyroid hormones and or the synthetic analogs. So another reason I don't need you to memorize this is because each patient is different. Each patient is going to require a different titration of these drugs, and you'll usually see if sometimes if the patient is suffering from hyperthyroidism and they go to get their thyroid removed, sometimes the patient will then consequently develop hypothyroidism. So it's really essential for hormonal replacement, thyroid hormonal replacement, to be implemented after the thyroid is removed. The parathyroids are essential in regulating calcium homeostasis. And as you all know, calcium is essential for many different physiological processes, including synaptic transmission, muscle contraction, and bone mineralization. So the big thing I want you to know is that as blood calcium levels increase, PTH levels are going to decrease. Parathyroid hormone levels decrease as blood calcium levels rise. If for some reason the patient gets the parathyroids removed or they're destroyed, it could result in convulsions and the patient could die because of inadequate plasma calcium levels. So again, as the plasma calcium levels diminish and regress, this is going to activate PTH, the parathyroid hormone secretion. So PTH is going to act to increase the blood calcium levels in the bone, the kidney, as well as in the gastrointestinal tract. And PTH is also essential to help increase the absorption of calcium from the gastrointestinal tract. Parathyroid hormone also directly affects skeletal tissues by increasing bone turnover. And by increasing bone turnover, what this does is it liberates calcium from skeletal stores. And it can be counterproductive. If we have too much PTH, what that can do is that can actually enhance the development and the action of the osteoclasts, which we remember help to break down bone. Again, the osteoclastic activity will essentially degrade the collagen matrix within the bone, and what that will do is essentially release calcium into the bloodstream. PTH also increases the plasma calcium levels by increasing the renal absorption of calcium, and as the renal calcium reabsorption increases, PTH produces a simultaneous increase in phosphate excretion by inhibiting phosphate reabsorption in the kidney. Now, those few facts I just mentioned, that's kind of just for your general knowledge of how all of this is working. The big thing I want you to focus on is how calcium and PTH have this antagonistic relationship. So pay attention to that and just understand the general mechanism of how PTH works. As I mentioned previously, the high levels of parathyroid hormone can actually accelerate bone breakdown. They can accelerate the production of the osteoclasts and actually have a catabolic effect on the body. So I hope from pathology and anatomy that you remember osteoclastic activity versus osteoblastic activity. Osteoblasts are building the bone, osteoclasts are breaking down the collagen matrix. Moderate levels can stimulate osteoblastic activity, but again, high sustained levels can stimulate the unwanted effect of facilitating osteoclastic activity. Vitamin D is really essential for bone formation, as you all know. It enhances bone formation by increasing the supply of calcium and phosphate. Vitamin D also works to suppress the synthesis and the release of parathyroid hormone from the parathyroid glands, which is an effect that tends to promote bone mineralization by limiting the catabolic effects of PTH. Vitamin D can also help to liberate calcium from skeletal stores and help maintain plasma calcium levels in an acceptable range. Calcitonin and calcium have this antagonistic relationship, so calcitonin helps to lower blood calcium by stimulating bone formation and increasing the skeletal storage of calcium. Other hormones that bone mineral content include are the estrogens, the androgens, growth hormone, insulin, as well as the thyroid hormones, which I've mentioned already. So listed on this slide in table 31.4 are some different examples of metabolic bone disease. So you all should be familiar with everything except for, I don't think I mentioned renal osteodystrophy or Gaucher disease in pathophys, but definitely just review all of these, and these are really important for your board exam. This isn't going to be, the pathology again is not going to be tested in pharmacology, but I would highly suggest for you to review the pathophys of each one of these conditions. So it's really important to maintain a balance of blood, an appropriate balance, an appropriate level of blood plasma calcium levels. So it must be, again, you don't have to memorize this range, this 8.5 to 10.4 milligrams per 100 mils, but just know that the blood plasma calcium has to be maintained within a normal physiological range for physiological events and homeostasis to occur. If plasma calcium levels fall below 6 milligrams per 100 milliliters, then the patient may go into tetanic muscle convulsions rather quickly. And if we have too much plasma calcium, if we have above about 12 milligrams per 100 milliliters, this can result in a depressed nervous system, leading to sluggishness, lethargy, and possibly could even render the patient into a coma. Calcium supplementation is really important to ensure that calcium levels are adequate for all the physiological processes. And they help to prevent bone loss in conditions such as osteoporosis, osteomalacia, rickets, and hypoparathyroidism. And calcium is often combined with vitamin D and some type of bisphosphonate, which we're going to talk about in a little bit, in order to achieve an optimal bone density effect. So calcium supplements are highly recommended in preventing and treating osteoporosis in postmenopausal women. And please note that calcium supplementation is going to be unique for each individual, but it's recommended not to administer more than 500 milligrams of calcium at once, and the dosage that is used to prevent fractures should not exceed 1,000 milligrams per day. So again, you don't need to know these doses. This is just kind of for your general knowledge, but if you notice that the patient is taking an excessive level of calcium, this is something that you could consult with the MD on. And if In order to recognize this, the patient may be complaining of constipation, confusion, irritability, heart palpitations, hypertension, nausea, vomiting, skin rashes, and just general pain. So if you notice this during your PT treatment, these all could be signs and symptoms of too much calcium, and you should review with the patient how much calcium he or she is taking, and then consult with the MD to get the calcium supplementation under normal physiological balance. So the bisphosphonates, alendronate and pamidronate, definitely know that suffix, dronates, bisphosphonates, kind of rhymes, or it does rhyme. They both inhibit the osteoclastic activity, so they inhibit the cells that are causing the breakdown of the collagen matrix of bone. And patients with Paget's disease often use bisphosphonates to help prevent exaggerated bone turnover and helps to promote the adequate mineralization. The bisphosphonates can also help prevent and treat bone loss during prolonged administration of anti-inflammatory steroids, and they're also used in postmenopausal women to improve bone health. They're used in postmenopausal women to improve bone health now as the main treatment. Remember earlier, to improve bone health, women were given a lot of estrogen, but we've come to learn that estrogen has a lot of side effects. So the bisphosphonates are pretty much the go-to to treat osteoporosis in postmenopausal women. But please note, again, with one of the major side effects, if the patient's taken too much of the bisphosphonates, or they're taking it for too long of an extended period of time, it can result in osteonecrosis of the jaw. And osteonecrosis of the jaw is often seen in patients receiving the drugs intravenously, and is often seen in patients that have some type of other comorbidity. It's not very common to see, but something you need to be aware of. So patients who are receiving radiation or chemotherapy for some type of cancer, or if the patient's taking other drugs such as glucocorticoids. The glucocorticoid administration can actually agonize the side effects of the bisphosphonates. And now we move into calcitonin, which can be given intramuscularly or subcutaneously. And endogenous calcitonin decreases blood calcium and promotes bone mineralization. So please note that calcitonin and plasma calcium are antagonists. When one goes up, the other goes down, and they work just like the other things we talked about with physiological balance, for instance, insulin and glucagon, how they go up and down as well. Calcitonin is used to treat hypercalcemia and decrease bone resorption in Paget's disease, and it's also used to help prevent bone loss in postmenopausal women who are suffering from osteoarthritis, osteoporosis, or if those patients are taking glucocorticoids for an extended period of time, if there's potentially glucocorticoid-induced osteoporosis. As you all know, estrogen is critical in maintaining the adequate bone mineralization in women, but estrogen replacement therapy does pose its risks. It can increase the risk of cardiovascular disease and even facilitate the development of certain cancers. So it's no longer considered the gold standard for long-term management of postmenopausal women with osteoporosis. The gold standard of management is going to be the bisphosphonates. So, and if the woman still needs estrogen replacement, please note that bisphosphonates don't really do much in terms of estrogen regulation. But if the woman needs some type of ERT, they're usually going to be given some type of SERM, which we've talked about, a selective estrogen receptor modulator. So remember, tamoxifen is the first one that was approved by the FDA, but tamoxifen is not specific, and it does have effects on the uterus. So they're prescribing raloxifene now. So raloxifene activates estrogen receptors on certain tissues such as the bone, but it blocks the effect of estrogen on the breast and the uterine tissues. So with this whole section, I really want you just to know the general pathophys and be aware of the potential side effects that these drugs impose. So please read through the special concerns for rehabilitation patients, as this is very informative.